Khong is currently a senior staff consultant at SA Pathology based at the Women's and Children's Hospital. Professor Khong is internationally recognised for his expertise in obstetric and perinatal pathology and has been a recipient of an American Cancer Society Eleanor Roosevelt International Cancer Research Fellowship awarded by International Union Against Cancer, Royal Australian and New Zealand College of Obstetricians and Gynaecologists Excellence in Women's Health Award, and the John Emery Lecture Medal awarded by Paediatric Pathology Society. He's the author of 3 books: Keeling's Fetal and Neonatal Pathology, Pathology of the Placenta, and Diagnostic Endometrial Pathology. And he's going to be talking on embryology of the normal placenta. Thank you, Yi.
Okay, thank you very much for inviting me to present at this Brian Pridmore Memorial Lecture. I had the pleasure of working with him when he was chairing the Perinatal Subcommittee of the State Mortality Committee, and he was a really true gentleman. Anyway, I'm going to spend some time talking about the embryology of the placenta, but really it's quite a boring subject, so I'll deviate from that, but that was a title given to me. Has it moved? Okay. This doesn't move, yeah? Okay. So what I want to do is touch on the implantation of the embryo and the blastocyst, and talk about vascular components of the placenta. And then there are really three compartments, or if you like, that pertain to the vascular supply. Then I want to talk about a mixed pregnancy because that is of interest to the women and to midwives and obstetricians when they want to counsel the woman and the partner regarding the mixed pregnancy. Because I'm a pathologist, I can't leave without telling you something about the examination of the placenta. So these are cartoons about the. So this is the blastocyst when it's just sitting on the luminal surface of the uterus. So these are what we call a pre-implantation blastocyst. This is about day 4 or 5. You can see an outer layer of what we call a trophectoderm, and then there's an inner layer here, which is the inner cell mass. Later on, at day 7, it starts being embedded into implanting and embedded into the endometrium. The endometrium starts being decidualized, so it provides nourishment to the growing blastocyst and later the fetus. And here it is truly embedded within the uterine cavity, and this is about day 14. What is interesting here is the inner cell mass. It starts dividing, and from the inner cell mass, we start giving rise to what we call the extra embryonic mesenchyme that starts filtering out into the developing placenta. So those are cartoons, but the cartoons are based on real specimens, and these specimens. There are 2 very good collections. One which is called a Boyd collection, based in Cambridge in the UK, and another one is the Carnegie collection, based in the US. And they are a resource for researchers wanting to look at the implantation and the development of the placenta. So what happens next is we talk about the compartments. I want to talk about that in particular. There will be the fetal circulation that comes in from the top, where the placenta starts arborizing and starts dividing. So you get a primary villus, starts dividing very much like a tree, growing up from the bottom of the ground with a big trunk, bigger branches and boughs, and then you have smaller branches and smaller trees. So you have a primary villus, secondary villus, and then tertiary villus, and then you've got terminal villi. Your terminal villi being your leaves. The extra embryonic mesenchyme starts shooting down what we call mesenchyme, which are sort of progenitor cells, into the primary villus, and then shooting down further into the secondary and tertiary villus, and then they start differentiating into blood vessels. So this is how your fetal circulation develops, and I'll show you some illustrations of that later on again. The maternal circulation is slightly different. The placenta derives its blood supply from a combination of the ovarian artery and the uterine artery. They penetrate through the uterus and then ends up as what we call the spiral artery. And it's a spiral artery that's of importance to us because what happens is during a normal non-pregnant state, the spiral arteries are very muscular and they just don't have a very little blood flow through them. But what it does need is to adapt to a growing conceptus, and by doing that, it has to change and become a very much compliant, low resistance vessel, such as you can see in the lower diagram. So it is for expansile. It can be because of the increase in blood volume in the woman during pregnancy. It passively dilates, pushes through a tenfold increase in blood flow compared to the non-pregnant state. So this helps in developing. Again, some cartoon to show you how that works. Initially, you've got your villus, your villus sitting at the top. It sends down what we call extravillus trophoblast. Trophoblast is coming down infiltrating into the mother's decidua, and also into the spiral arteries. And it's those trophoblast cells that go into the spiral arteries that convert them from very small spiral arteries into very dilated, what we call uteroplacental arteries. You can see that schematically. Again, those are diagrams, but they are based on real specimens. And this is what you see in early pregnancy. And you can already see that the spiral artery sitting on the lower left is already being dilated, very much losing this muscular and elastic tissue. And this is and you can see that this is in the myometrium. So in the superficial layers of the myometrium, the trophoblast is sitting right in the middle of the spiral artery, again trying to do the conversion into what we call uteroplacental arteries. And then by term, you will see that these are very much dilated, very big, very tortuous vessels pushing through a large increase of blood flow through the placenta. You can imagine that in a pregnant state, if it's not a histological diagram, which is actually rounded and very much a large caliber vessel. So schematically, we can see that the spiral arteries, instead of being muscular, is all converted from the decidua. You can see the hatch bit. And then all the way down into the superficial segments of the myometrial myometrial segments of these spiral arteries. What happens in abnormal pregnancies, and we talk about abnormal pregnancies such as preeclampsia, intrauterine growth restriction or fetal growth restriction, and also in spontaneous miscarriages, is that the trophoblast does not infiltrate down from these villi. And so you've got a sparsity of trophoblasts in the decidua. You also got a sparsity of trophoblasts infiltrating into the spiral arteries. And the net result of that is when you compare it with the more purpley stuff on the top left, those are the extravillus trophoblasts coming down, and in the bottom right, you've got far less amount of these trophoblasts coming down. So the net effect of that is that the spiral arteries are no longer converted, and this is really taken at the same magnification. You can see one of them in the larger picture. The spiral arteries are very much smaller caliber, don't provide so much of the blood flow through to the growing conceptus. Schematically, this is what it looks like. It looks like it's not dilated, doesn't give you that through flow of blood. The net result of that, when you look at the placenta, sometimes you can see the infarct, sometimes you can see them grossly. Is really until you slice it that you can see the extent and the distribution of them. And these are the white plaques are where what we can confirm histologically as infarcts, and because the blood supply is limited in these pregnancies. So these are just again another cartoon to show between a normal and a preeclampsia. Anything where there is what we call maternal vascular malperfusion, so preeclampsia, fetal growth restriction, early and miscarriages in early pregnancy. So the fetal circulation, I touched on that very briefly. So what you have is on the left side, you have a very early pregnancy. You have two layers, syncytial trophoblast and a cytotrophoblast. The cytotrophoblast expands, provides the progenitor cell to the syncytial trophoblast. As pregnancy expands, you've got more and more of the vessels coming down from the extraembryonic mesenchyme it starts going from being centrally placed in the villus, going to the periphery. The trophoblast layer starts thinning out so that you have a very much closer proximity between the fetal circulation and the maternal circulation, which is the intervillus space. The connection between the fetal heart and the fetal placental vessels doesn't begin until about 32 days post-conception. But after that, it starts providing that fetal placental circulation that takes place. Now, while all this is going on, the surface area of the placenta increases, and at term, the fetal surface area of the villi on the surface is about 12 to 14 square meters. When you think about the human adult, female about 6 square meters skin, male adult tall one about 8 square meters. So this is about a very much larger component of a surface area that is provided by the placenta. Let me check on that. I think it's 6 to 8 fold, in fact. Yes, sorry. It's 6 to 8 fold increase. So I think the normal female is 1.4 square meters, and the adult male is about 1.6 square meters of skin. So this is a much larger 6 to 8 fold increase in surface area in the villi compared to just our skin. If you think about how we have the skin as a sort of exchange of heat and such things. So this is just a schematic diagram again of how the vessels start from being in the middle of the villi, and then it starts going outwards into the periphery and the thinning of the trophoblast layer. So what can happen? What can go wrong with the fetal circulation? Well, sometimes there can be vasospasm, and here you can see this. You can see that instead of being very dilated, the fetal vessels themselves are very constricted. And the net result of that, you can see sometimes on the surface, there's a white plaque here, and this is a thrombosed fetal vessel. And this is a sort of illustration of that, the white vessel there, thrombosed. So again, the circulation through these fetal vessels will also be compromised. This is a thrombus sitting at the bifurcation of a large stem villus. So again, illustrating what happens. And what happens is that instead of circulation through the fetal vessels in the villi, you can see that you've got a plaque of avascular villi. So this is a real event that goes on. Net effect of thrombi in the fetal vessels is that they are likely to shoot off into the fetal circulation. If you remember, in the fetus, they've got a foramen ovale, so these thrombi don't actually get trapped in the lungs. They can go through the foramen ovale, go through the brain, and you can get your thromboembolic phenomenon in the brain. You can have a child or an infant with cerebral palsy from fetal vascular thrombosis. Just very briefly on intervillus space, it's all that space that is sitting in between the villi, where it is bathing the villi. And this is a very good illustration of what can go wrong, for example, in the intervillus space. In 2020, 2021, we're talking a lot about COVID-19. That's about 18 months ago. What happens is that there's a lot of angiotensin converting enzyme receptor on the trophoblast. The COVID-19 uses ACE to hone in as a receptor to sit around, in adult vessels, for example, and therefore in the placenta, because of the trophoblast ACE layer, the COVID will sit on the trophoblast layer. It damages the trophoblast layer, and you can see the damage by the top right-hand side. By what we call a complement C4D is a marker for damaged mucosal surfaces. So C4D is complement deposition in the trophoblast, and what happens then is that you've got infiltration of a lot of histiocytes. So in effect, we're getting what we call a chronic intervillositis, not dissimilar to the one you get with with miscarriages, where people have women get repeated miscarriages because of chronic histiocytic intervalocytes. So the same phenomenon going on with COVID-19. Not dissimilar also to malaria for that matter, and although we live in a very privileged part of the world, malaria is a very much a leading cause of maternal and certainly infant mortality and stillbirths worldwide. So I want to talk very briefly on what happens post-delivery in the next pregnancy. You can see that this is a non-pregnant state. You've got your spiral artery is very muscular, a lot of muscular and elastic tissue. And then you become pregnant, you have a very large dilated one, you've lost all your muscular elastic tissue, large throughput of blood supply. Now this can go on obviously when when a woman is no longer pregnant, because then you'll be having a lot of postpartum bleeding. So the arteries have to involute, and involute very rapidly, and by undergoing what we call involution. They involute by being hyalinization, and they also start recovering their muscular elastic tissue. So it's a cycle, and it becomes the next state of menstrual cycle again. But what happens for a pregnant woman is that there is a morphological memory. By morphological memory and also immunological memory. By morphological memory, what it is that in the non-pregnant state, you've got all this muscular elastic tissue. The muscle is shown by the red amount of red tissue there. And then if you are pregnant, especially if you've been pregnant more than once, twice or three times, then you can see the amount of muscular tissue is much more diminished. And the proportion is very much different. And the difference is most marked between a woman who has never been pregnant compared to those who have been pregnant at least once. So the 0 and 1. The elastic tissue is also more fragmented. You can see that it's very nice and neat here and on the left side. And then when you have a woman who's been pregnant, this one is parity 4, you can see it's very fragmented, a lot of disruption to the elastic tissue. So we think this will account for the fact that the trophoblast is easier to infiltrate the vessels during early pregnancy. It's also easier for these vessels to then change and transform from a spiral artery into another uteroplacental artery. And that will account for why the second-born infants are usually bigger in size than the first-born infants. May account for the fact that preeclampsia is less likely in the second pregnancy compared to the first. Also account likely for the fact that miscarriages are more likely to be sporadic rather than being recurrent. Oops, wrong way around. Okay. The other thing is also the immunological phenomenon memory. The natural killer cells are kind of a immunological leukocyte that sits around the spiral arteries. And they also sit around in the interstitium and the decidua, increasing in numbers from proliferative through secretory phase, and certainly in the decidual when it's decidualization and during pregnancy. And this is a cartoon taken from an article by Dr. Harris, and he says that look, the natural killer cells provide a lot of cytokines, amongst which is VEGF, vascular endothelial growth factor, alpha, and interferon gamma. And what it does is that they do help in modeling the spiral artery. And this is a lovely paper from a group in Israel, Tel Aviv, and showed that in those women that have, from the decidua of women who've had been pregnant before, the numbers of natural killer cells are increased, and they also have a memory, and they produce more of these interferon gamma, more of the VEGF alpha as well. And so they will be helping, again, to help transform the spiral arteries. They term this cohort of natural killer cells in the second and subsequent pregnancies as pregnancy-trained uterine natural killer cells. So this is an interesting thing to learn about how the woman's uterus can retain a memory from a prior pregnancy. As I said, this explains the second-borns being bigger, low incidence preeclampsia, and the likelihood of whatever. Now, if all this is very confusing to you, it doesn't matter. What I want to say is that as a if you are at all in doubt, send a pathology, the placenta for pathology. By and large, we are not getting enough placentas. There are two sets of guidelines. One must be sent, which is R, and somewhere it would be nice if we are sent, which is R plus. As you can see in the first two columns, we are examining maybe about 33% of what placentas that should be sent. About 60% that ideally should be sent are not being sent. It's nice to know that we are not examining that things that shouldn't be sent, we're not being sent. Now, this is it is serious if anything, because for those of you who are around this while, the Fever Hospital was shut down in 1995-96 after they lost the cerebral palsy case. I think the case was settled for $12 million. The insurance was not sufficient to cover and had only $5 million cover, I think. So that hospital was shut. Sorry, I think it was 1.2 million. I think they had covered a $5 million payout. So this is 1995. You fast forward it about 20 years later. This is taken from an advertiser, and you've got people, women. It's tragic, yes. Cerebral palsy. You've got being sued for $60 million. So I thank you all for your attention, and I'll take questions at the end.